I would like to thank the organizers for giving me this opportunity. My topic is evaluation of Tele Ophthalmology screening camps in detecting diabetic retinopathy and non-diabetic retinal diseases. I am Dr. Sheila John from Sankara Nethralaya, Chennai. I have nil financial disclosures. Due to coronavirus, there was a pandemic and there was difficulty in conducting camps in the rural villages because government did not give us permission. Chronic disease management in primary eye care during the COVID-19 pandemic was very difficult, and it's imperative that diagnosis of ocular diseases with special attention to retinal diseases at a very early stage is necessary to prevent visual loss. The government did not give us permission from March 2020 to February 2021. From March 2021 to May 2023, we had government permission, and with the help of District Blindness Control, and we followed the COVID protocols and conducted camps in the rural villages. In this study, we evaluated sight-threatening ocular diseases with special emphasis on retinal diseases, diabetic and non-diabetic. Reviewed results to determine major causes of visual impairment and blindness due to retinal diseases. In Sankara Nethralaya, the personnels who were in the central hub were connected with Tele Ophthalmology was a technical coordinator, information and technology persons 3, assigned ophthalmologist. At the campsite, we had optometrists 4, social workers, a driver, optician, project officer, and fundus photographer. Electronic medical records at the campsite is offline. One laptop acts as a server, and with the help of Wi-Fi router, it is connected to 4-5 laptops. Entry is made for demographic details and for clinical examination done at the campsite, and also we upload the ocular images, both anterior segment and posterior segment. At the hospital, the main laptop server data is uploaded in the server at the hospital and stored almost every day or alternate days. When patient reports at the hospital, details of examination at the campsite can be viewed in the EMR. We had a single EMR sheet with demographic data and comprehensive ophthalmic examination. I would like to explain the various procedures conducted at the camp.
Due to the COVID-19 pandemic, the eye camp activities have been restructured since March 2020 as per the Government of India guidelines. The COVID-19 protocols are strictly maintained in every camp in both rural and urban areas. One such camp was organized in the rural areas in Periyavayyavur, Kanjipuram district on 7th of August 2021. A middle school was chosen as the campsite after obtaining necessary approval from the local bodies. Our hospital staff went to the campsite along with the instruments, and necessary examination stations were organized. Patients at the campsite were required to wear a mask and to follow strict COVID-19 protocol. Patients are instructed to use hand sanitizer using an alcohol-based hand rub for 20 minutes and are seated in the patient's waiting area after ensuring adequate social distancing between patients. The patient's temperature is then checked and noted in the patient's identity card and are registered electronically in the EMR system along with the name, age and address and other demographic details. The optometrist then performs autorefractometer after wearing a mask and a face shield and after using a hand sanitizer. This is then followed by a detailed history taking after ensuring sufficient social distancing is maintained. The optometrist then tests the distance visual acuity after disinfecting the trial frame, occluder, or by asking the patient to close one eye after using hand sanitizer. The near vision chart is held by the optometrist instead of the patient after hand sanitization. Patients who cannot read charts in languages are tested using the illiterate e-chart. This is then followed by pupillary examination and examination of extraocular muscle movement. Patient's spectacle power is then examined using a lensometer, and the details are entered in the electronic medical record system. For the slit lamp examination, the patient's chin red and the forehead rests are cleaned, and with the optometrist wearing a mask and a face shield, and the patient undergoes ocular examination. In case of any systemic diseases, the patients undergo undilated photography, and in the presence of any abnormal retinal findings, the patients are referred to the base hospital for further evaluation. Social distancing is maintained with only 5 patients in a room at a time. The teleconsultation is arranged between the patient, the optometrist at the campsite, with the tele ophthalmologist at the base hospital. Patient's findings are then shared with the ophthalmologist through the electronic medical records, and the patient's consultation is improved with a real time consultation with the ophthalmologist. The ophthalmologist examines the slit lamp and other photographs and provides further advice to the patients. The patients are then referred to counseling. Once the patient has been diagnosed cataract or other ocular complications, the camp coordinators or counselors provide referral and give clear instructions for patients. For patients requiring only a change in glasses, they are referred to the optical shop where their interpupillary measurement is taken. The patient is then presented with a choice of frames. Once finalized, the glasses are made and dispensed later at the village with the help of the donations. So this is a summary of the camp statistics shown here. This camp examined 70 patients. A majority of patients had refractive error and were advised spectacles based on the visual needs and requirements.
Results March 2021 to May 2023 in the Tamil Nadu unit during the COVID period. Number of camps were 430. Number of patients examined were 40,622. Teleconsultations were 1,760. Total retinal diseases were 996. If you see the ratio of males and females, males is 42%, females is 57.8%. For all retinal diseases, teleconsultation was done and it was clearly explained to the patient the nature of the disease, and then the patient was referred to the base hospital for further investigations and treatment. Retinal diseases COVID-19 period March 2021 to May 2023. The total number of retinal cases, as discussed earlier, was 996. Now I will be discussing the breakup. In the camps, diabetic retinopathy cases were 557, which is almost 50%. And we were able to see many patients with high myopia in the camp, and hence 213 patients myopic chorioretinal degeneration and other forms of healed chorioretinitis. Age-related macular degeneration were about 78 cases. Majority was of the dry type with few cases of wet type. Macular edema, scar and hole were 57 cases. Many patients had diabetic macular edema. Few cases had macular edema due to age-related macular degeneration. There are few cases of macular scar and one case of macular hole. We were also diagnosed 19 cases of retinitis pigmentosa. In the 27 cases of retinal detachment, many were tractional retinal detachment and few cases were regmentogenous retinal detachment. In cases of vitreous opacity, we diagnosed 4 cases of astroid highlightis, 20 cases of disc pallor, glaucomatous disc pallor, optic atrophy due to optic neuritis, and 1 case of papilledema. 21 cases of branch retinal vein occlusion and central retinal vein occlusion. Majority of the cases were branch retinal vein occlusion with macular involvement, and few cases were of central retinal vein occlusion. Diabetic retinopathy. The total number of patients with diabetic retinopathy was 6,335 with diabetes mellitus. out of which 557 patients had diabetic retinopathy. So it is 8.8%. As the total patients were with diabetes 6,335, out of which diabetic retinopathy is 557 and the percentage is 8.8%. As the diabetic patients 557 had 2 eyes, so the total eyes with diabetic retinopathy was 1114 eyes. The normal eyes were 85, mild and moderate non-proliferative diabetic retinopathy was 807, severe non-proliferative diabetic retinopathy was 165, diabetic macular edema was 147, proliferative diabetic retinopathy was 57 cases. Hence, it's very, very important to advise the diabetic patients to undergo annual dilated eye examination. This is a case of diabetic retinopathy. One eye you can see proliferative diabetic retinopathy and the other eye you see hard exudates with macular edema. This is sight-threatening diabetic retinopathy. This is a case of non-proliferative diabetic retinopathy with diabetic macular edema. Here again, you see cercinates in the macular area in both the eyes and the macular reflex is dull. This is a case of non-proliferative diabetic retinopathy with diabetic macular edema. It's a case of retinal detachment and you can see not the normal retinal reflex, you see the grey dull retinal reflex. We saw many cases of high myopia. This is a case of myopic chorioretinal degeneration. Now in this eye, ungradable retinal image is seen in the right eye. We are not able to see the retinal details. In the left eye, you can see diabetic retinopathy with retinal hemorrhages. This is a case of age-related macular degeneration in both eyes. You can see the drusen approaching the macular area. This is a case of astroid highlightis, which is opacity in the vitreous cavity in the right eye. Left eye is a normal eye. This is a case of macular hole. You see in the right eye is normal. Left eye you can see the macular hole, surrounding edema and a few hard exudates. This is a case of papillary edema where you see the disc is elevated, edematous and hyperemic in both eyes. This is an emergency and has to be referred to the neurophysician or neurosurgeon. This is a branch vein occlusion, which is a normal fundus image in the right eye, and left eye, superior temporally, you can see a lot of hemorrhages, hard exudates and soft exudates, and you can see the macular edema with the macular star. This is a typical case of branch retinal vein occlusion. Now, coloboma of the choroid and retina is a congenital condition. The right eye is normal. The left eye, there's a coloboma of the choroid and retina, which is seen involving the disc. Now, retinitis pigmentosa is a degenerative condition, and you can see the dull reflex with bone scopule pigments in the periphery. Now, for every diabetic patient, it is very important awareness is created. Knowledge, attitude and practice on diabetes, that they undergo a dilated eye examination every year, annually. References. I have shared important references. One such is Practice Guidelines for Ocular Telehealth for Diabetic Retinopathy, 3rd edition 2020. Now, future implementation utilizing ultra-wide field fundus photography in the telescreening at the telescreening site. Implementation of artificial intelligence in telescreening for diabetic retinopathy and other retinal diseases. Utilization of clinical support system with electronic medical records. It is important to create protocols for normal, abnormal and poor image quality images for retinal images, and all abnormal and poor quality images have to be referred to the hospital for further investigations and treatment. A Tele Ophthalmology unit conducting eye camps is a cost-effective tool to detect sight-threatening retinal diseases and prevent blindness. Our Tele Ophthalmology camps provide reach of patients for eye care to medically underserved population in rural areas. Thank you very much. I would like to thank the organizers once again for giving me this opportunity. Thank you.